Thank you, everyone at AHIN for the opportunity to speak to you. And I'm really honored to be among a lot of friends and also having the opportunity to share with you the digital health journey that is happening in India at the moment. So, in the next 20 minutes or so, I will be sharing with you the overview of a policy framework that India has adopted towards universal health coverage. And I will also give you a small context of the health systems reforms that are going on in India and how digital health is playing an important role and what is the vision of the National Digital Health Blueprint, core principles, its building blocks, and its framework, particularly on standards, and what has the journey been so far, and what is the anticipated road ahead. So, as many of you would be aware, and India is a very populous country, and we have a large number of people who are living in rural areas, and most of our healthcare facilities are primarily situated in um, tertiary level centers and in cities and at maximally at the district level. And as you go lower down in the hierarchy of healthcare delivery, the specialties that are available and even services that are available at the peripheries are limited. So you can see that this is on the left is a hospital. Sorry, on the right is a hospital where one bed is being shared by many patients. And so we definitely have a supply to demand mismatch. And that's largely because of the mismatch in the number of beds that are there, or in the mismatch in the number of healthcare providers that are there, or even just the number of facilities that are available. So, in the Indian government, as a signatory to the commitment to universal health coverage as part of the Sustainable Development Goals, has launched two key mechanisms by which they want to ensure that anybody who needs healthcare access is able to do so without much financial constraints, and also in the best manner possible. So that there are two components of the universal health coverage in India, and one component of that is strengthening of health services delivery through health and wellness centers. So it is anticipated that 150,000 health and wellness centers would be established in the course of um, a matter of a couple of years. And this is primarily to strengthen primary healthcare services in both in urban as well as in rural areas, particularly in rural areas where a bulk of the population lives. And the other component of the universal health coverage program, popularly known as Ayushman Bharat, is about making sure that people who are needing healthcare services have access to that, and particularly those who are below a certain economic level, who do not have access to healthcare services and who cannot pay for it, have access to that through a state sponsored health insurance program. And this program is called PMJY or Ayushman Bharat. So, like, just to set the context, there are two major reforms that are happening, and the context of this comes from the national health policy that was drafted in 2017. And it also envisages that a co-component of the health reform would be around a creation of a digital health ecosystem, which is an integrated health information, which probably will bank on integrated health information system that aims to improve efficiencies, transparency, and citizens' experience that links across both public and private healthcare sectors. And another vision document that has been created by Niti Aayog, or the planning body of the government, is about creating of a national health stack. So basically, national health stack is core of principles or building blocks that is billed as public goods, and it is making sure that all efforts towards the health reforms, as well as particularly focused on the digital health efforts, are not duplicated, and there is convergence among the different IT systems across different stakeholders that covers governments, the payers, the providers, and citizens. If you were to go back to my previous slide, many people who are proponents of digital health interventions and telemedicine tend to think that just connecting the dots between where people live and healthcare facilities is going to take care of all the challenges that India faces in terms of health systems capacity and healthcare delivery. But at least those of us on this call would well understand that digital health tools are just an enabler, and it is a health system that needs to be strengthened. Therefore, our national health policy, as well as the national health stack, and broadly when we come to the national digital health blueprint, it envisages to actually create a digital health ecosystem. There cannot be a digital health ecosystem without a robust healthcare delivery ecosystem. So I would want to emphasize that the health reforms in India is addressing access to health services, taking care of um, ability to pay for those services, and improving those services both in rural areas and in urban areas, while also using digital as a platform to achieve that. Okay, so the National Digital Health Blueprint is a mechanism by which it would support universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner through providing a wide range of data, information, infrastructure services. And it aims to leverage open, interoperable, standard based digital systems while ensuring security, confidentiality, and privacy of health related personal information. So, this is the context of the National Digital Health Mission, which came out of the National Digital Health Blueprint. So, in a nutshell, National Digital Health Blueprint is basically derives its origins from the National Health Policy, which is the agenda that the government has put together for health systems reforms, and it aims to achieve the highest level of health and well-being for everyone at all ages, better access and better quality of care at affordable cost or improved cost. It aims to have citizen centricity. Here, digital becomes an important component because many people have access to telephone services as well as smartphone services, and therefore if you were to engage a citizen and to put the citizen at the center of this whole universe, you would need to have touch points that are easily able to relate to the citizen, and therefore the digital platforms make immense sense. One of the challenges that I did mention earlier is that lot of people live in rural areas, but they tend to seek higher specialty level care in cities or at tertiary care centers. But when they go back, many of them would need a continued care or the continuum of care. So here again, the digital platform or digital tools have an immense role to play. So therefore, both the National Digital Health Blueprint and the the National Digital Health Mission envisages to use digital as a lever to achieve both citizen centricity as well as continuum of care. And of course, as of all of us know, that when you have information in digital format or in electronic format, we can look at data from a perspective of performance, and we can bring in accountability structures, and one could shift from silos to a holistic health centered ecosystem or a person centered ecosystem. And all of this, we in India want to achieve it through a federated national health information architecture. So, in terms of there's a broad vision, there are principles, there are architectural building blocks which ride on standards and regulation, and it envisages an institutional framework and an action plan. So what we are going to hear about in the next couple of minutes is about National Digital Health Mission, which is the institutional framework that is going to translate this vision for health systems reforms and healthcare delivery, improving healthcare delivery using the lever of digital health, and some of the actions that have happened so far. So again, I would want to reiterate that it calls for a federated architecture, which means that data tends to be means it's envisaged that data would stay closer to places where it is being collected, and it will be meaningfully used people who are at closest source of where the data is generated, as well as where meaningful insights can be derived from it and they can act on it. Typically, systems, health information systems, tend to collate a lot of data centrally, and then there is centralized decision making, and there is very little action on the ground. And this is several systematic reviews have shown that the uptake of digital tools or health information systems have been not being that successful, primarily because of this reason, because people who collect the data are not meaningfully able to use that, and therefore India has emphasized that it will go for a federated architecture that allows this to happen. And like I mentioned, open standard and open API policies would allow the both the social sector and the entrepreneurship sector to innovate. And once there is an architectural framework, there would be a lot of innovative products and services that could be made available. So it looks at a 5-layered system of architectural building blocks. I will go into that a little later. One of the key parameters, one of the key components is being able to have a unique identifier for every citizen. So this project of the unique health identifier has already been initiated, and it has been rolled out in all the union territories. So union territories in India are directly under the central government, whereas India has a dual structure, and health falls under the dual structure of both, some of the governing principles being mandated by the federal government or the central government, and many of the decisions and implementation related decisions are taken by the state level. So this health ID has been rolled out in all the union territories, which are directly under the central government, and it has been largely a very successful exercise where the enrollment of people, citizens in the union territories, have been extremely successful. And as all of us are aware, it is very, very important to ensure that the consent of the person who is contributing the data is paramount, and all measures to keep privacy and security by design as a guiding principle. And because there, like I mentioned to you, there is a large scale movement for sake of seeking health happens in our country. Ability to port both the data as well as the schemes, the health schemes, such as the insurance schemes under which people can avail health services, should also be portable, and therefore a digital health architecture and an infrastructure would help in that. Electronic health record, like all of us know, is very, very important to make sure that we have longitudinal records and we are able to ensure continuum of care, and applicable standards and regulations for that. And when we have rich data through an electronic health record, we can do health analytics, and we can ensure that there is citizen centricity and engagement through the web, mobile, call centers, and telemedicine. It is increasingly becoming popular, particularly due to the pandemic, using of voice as an interface for engagement. And we've had several partners who have come and worked with the government on using voice as an interactive feature through IVRS, and provided support both for telemedicine as well as for COVID triage. And so having an architectural framework for that really is useful. So these are basically the domain principles as well as the technological principles. I wouldn't go into this too much. And I would like, basically most of us know that with health and wellness center in the center of the domain principles, the idea is to think big, act small, and scale fast. And that is the approach being adopted by the National Digital Health Blueprint, as well as the National Digital Health Mission. And all of the rest is basically summing in a thematic diagram for us to have a look. Okay, so if we were to look at this is from the National Digital Health Blueprint, and if we were to look at citizens as end users of the system, what are the components of the National Digital Health mission that would engage with them. So having a unique, secure health ID, a health portal, and perhaps a few health apps that allows them to maintain engagement both with their providers, as well as having their health records as a personal health record, and being able to do appointments or voice-based services, all of that. And um, for the health service providers as well as health professionals, particularly they would be engaging with digital health systems, digital diagnostic, e-prescriptions, as well as providing emergency services. In terms of public health institutions, wellness and information and engagement and communication, IECs, both health analytics and management of health schemes, registries for vital events, and disease registries, and maternal child health, and all of that. So, and if you were to look at it from providers or service providers, both from across insurance, digital pharmacies, call centers, logistics, ambulance services, right across the. And if we were to look at it from a technology service provider, though the opportunities are around health cloud, health network, health information exchanges, health lockers, interoperability tools, data hubs, security, privacy, analytics, and visualization tools. It's a lot to cover in 20 minutes, so but I'm just giving you an overview of what it's. So just to reiterate that on the health domain principles, the a core component of the health reforms is around health and wellness, and so NDHM will leverage the health and wellness centric approach, and it will be wellness driven, and therefore having real-time access to personal health records and empowering the citizens to have their own personal health record is one way to achieve this. And like we all know, providing information at the right time to citizens would empower them to make better informed decisions and also facilitate continuum of care, and therefore mass awareness and education is anticipated to be both leveraged through large platforms as well as voice-based services and health applications. um, One particular aspect that the architects of the National Digital Health Mission have envisaged is that these systems should not exclude anybody, because traditionally health delivery systems tend to exclude people who are living on the fringes of society, or who are um, unprivileged, or people who are geographically remote, or in specifically in hilly and tribal areas. So the design element and the principle of the design element would include inclusivity, and therefore all precautions would be taken to ensure that if there is no internet, the system should still work. So it is taking into consideration those kind of approaches as well. And like we mentioned before, data today is the most valuable component of a public good, and therefore a national policy on security of health systems and privacy of personal health data. The National Digital Health Mission had put out a draft about 2 months back, and as of yesterday, they have the approved policy that has been released for um, use, and it's likely to be approved and made mandatory as well. So in terms of technology principles, India is adopting the India Enterprise Architecture Framework. So this is not restricted to health. Right across the system of governance, there has been a systematic approach to have an enterprise architectural framework. So this enterprise architectural framework would be the backbone on all on which all the rest of the building blocks are going to be leveraged, and principles of interoperability. And India is a signatory to the open source software movement, and the government of India is committed to making sure that open source software products as well as open source development are the guiding principles, and federated architecture will be adopted by all aspects of the National Digital Health Mission. One of the key things to keep in mind is that the government has only taken for itself the responsibility of building the core building blocks, and it has envisaged that through both open architecture and architectural frameworks, as well as with open API approaches, is going to engage with all stakeholders who are going to contribute into the system. And I'll come to this later. Already an experiment around a sandbox is on to have all stakeholders engage with the architectural framework and to plug and play their services. So this is in a nutshell the federated digital health architecture. I wouldn't go into too much of the details, but it is envisaged that the end users would have ability to give consent, authorize a consent, and that consent will only last for a very specified time specified period and for that purpose. And the moment that consent, validity of the consent will be over, that data would not be repurposed or cannot be reused. So that is the design by privacy by design is already built in, and both for in terms of giving the real power in the hands of the end users and the citizens through a consent manager system. And this consent manager system is actually coming from the Ministry of um, Electronics and IT, and there is a framework that is being used by the Ministry of Electronics and IT right across the system for consent management, and a similar approach is being used for health as well. And it is envisaged that healthcare providers would primarily interact with the system through HMIS and laboratory information systems and aggregators of softwares, and there would be repositories and registries. And in terms of the other providers, they would again engage through these open API based approaches through the gateway, which are the registries. So far what has happened, so in terms of the so it is envisaged that the National Digital Health Mission is going to be rolled out in phases, and primarily the systems that are envisaged are the health ID. Like I mentioned to you, the health ID is already been launched in the union territories, and starting January it is going to be introduced in the other states, which is an ambitious plan. And um, hopefully it will work out very well. And DG Doctor is basically a registry of all the registered medical practitioners and other health professionals. All health facilities will have a unique identifier, and that is the health facility registry. And as I mentioned earlier, personal health records that citizens themselves can hold in the health locker and can give case-to-case authentication and consent for use based on whomever they want to share their data with. And electronic medical records, electronic health records, at the moment it is being used interchangeably, but perhaps down the line it will get defined a bit more, because at the moment in the vision documents as well as in the frameworks, it's being used interchangeably, both EMR and EHR. So, like I mentioned before, it basically envisages that minimum viable standards will be the approach in the initial stages, and particularly the standards that have been chosen, or the frameworks that have been chosen, as there is a consent framework which is from the Ministry of Electronics and IT, and the content and interoperability standard are going to be the 5 release 4, and there is a national resource center in India for SNOMED CT. And so this center is very deeply engaged in the working with the National Digital Health Mission and integral to the rollout of the various component of the National Digital Health Mission. And they have already come up with the India-specific releases, both for Indian system of medicines as well as for the allopathic systems of medicine. And right across the pandemic, they have been working very hard, and they are there to support any technology provider in India to comply to the electronic health records standards, or any of these architectural and standard frameworks that have been outlined. So in terms of privacy and security, while this has not been fully articulated, it is envisaged that there would be a privacy and security first policy, and keeping so the latest document calls for data protection officers at each of the facilities where a data fiduciary is responsible. A lot more work will need to be done, because these are the initial stages. Only as of yesterday, this document has been released, and now everybody is going to work and support the states and the government centrally in making sure that these principles are translated into practices. So, like I mentioned before, the journey so far has been that a national health ID framework has been put in place, and health IDs for a large number of citizens in the union territories has been issued, and that has been tried and tested, and it is going to be rolled out from January in the other states as well. The digital Digi Doctor, which is the registry of the health professionals, is already underway, and so this is the plug and play method that's being used. So the core components of the National Digital Health Vision being built by the government, and that being the architectural framework, and making sure that a sandbox environment is being created for anybody who is eligible to be part of the ecosystem and to build this ecosystem. So many of the Indian healthcare IT professionals and companies have been engaged with the sandbox and have been building use cases around use of this, and it, the responses has been mixed. Some are extremely happy, some have some concerns which probably needs to be addressed. So if you were to look at a broader vision, so this graphic kind of summarizes it all, putting patients and citizens at the center, with the providers, the health private health entities, health professionals, the development partners, regulators, program managers, policymakers, as well as the institutional providers, labs, pharmacies. Everybody can interact with the system, and that at the end of the day is an ecosystem, and that is a larger vision. So I think, yeah. So broadly, the National Digital Health Mission envisages an efficient, accessible, inclusive, affordable, and timely and safe system that every citizen will have access to. Again, keeping in mind that this is just a tool to achieve an end, and really would support the health systems as they strengthen through the 150,000 health and wellness centers that are being rolled out, and the large program of the insurance-led healthcare service strengthening is being scaled up. So thank you for this opportunity to share with you, and I'll stop here for questions.
Thank you, Dr. John. Without further ado, I would like to invite Dr. Min Sambat to share his experience.
Thank you, Ron, and thank you, Dr. John, for your great presentation about digital tool in India. So if you can share the document later on, maybe great. And in Cambodia, we just start for the national e-health strategy, or we call health digital strategy plan for 2021 to 2013, but not yet finalized. We still in process. But due to the COVID situation, this work was delayed, so that not much progress to get the plan yet. But we do still need the digital health plan also. And so far, Cambodia, we have a health information system, HMS, that use as a web application also, that starts in 2010. And we have patient management and registration system as a medical record, but mostly for the claim patient, that for the poor or non-poor who access to the healthcare in Cambodia, so that we track the patient. So I have one question for Dr. John. For the digital tool or medical record electronic that you link to the larger standard code for the disease like ICD-10 or ICD-11 still. Thank you. Yeah.
Yes, ICD is also being considered, and ICD-10 is currently in use in India.
Okay, and ICD-11 not yet. Yeah.
Not yet.
Okay.
I don't think the releases are yet incorporated, right? So it is anticipated in for use in Q1 of 21. Isn't that right? At least that
Yes.
is my understanding. I could be wrong.
Okay, and one more question that India have the good project on patient unique identifier, so that also linked to this. Can you explain more about the unique health identifier system in India?
Yes. So if I got your question correctly, yes, every city, it is envisaged that every citizen would be given a unique health identifier, and this is not the same as the social security number or the national identifier, because legal framework in the country has said that both this need to be kept separately, and that is why a unique health ID is separately being generated. Yes.
Okay, thank you. That's all from me. Thank you.
Thank you, Dr. Sambat and Dr. Chan. Now we invite Dr. Yadana Aung to share her insight and experience.
First, I would like to thanks to Dr. John to share the digital health mission topic. And in the Myanmar, in this period of the reform, we have an unprecedented opportunity to achieve the historic gains in advancing health for all by the universal health coverage approach. Last week, December 12 is the Universal Health Coverage Day, and also the National League for the Democracy (NLD) our government took the office on March 2016, and there we have a high hopes to the aspiration to attain the UHC by 2030. What we developed in the National Health Plan 2017 and 2021. Myanmar National Health Plan committed to extending access to the health services when they need and deliver the business essential package of the health services, and all townships will be covered by the comprehensive integrated healthcare for all people. While the digital health is not a universal remedy to the healthcare challenges, it has a vital role to play in strengthening health system. As the resource-constrained country like Myanmar, I think the mobile phone is a key component of the digital health. Mobile phone are the digital health solution that involve the use of the mobile device, network, and mobile-based solution. Myanmar has a policy on the digital health and established also e-health units in the MOHs. A critical moment came in since the 2030 when the government liberalized the telecommunications and leading the significant the syncet and also the exploration of the smartphone user and start up the ecosystem since 2013. And there has been a rapid growth of the mobile technology and the use of the Facebook, which are the opening new options for the digital health. For example, mobile money is the beginning to be used to provide incentive for the healthy behavior, and then the Facebook plays a key role in the communicating with the young people, and also the teleconsultation platform is quite popular in the Facebook Messenger. Also, Myanmar have an application of the Zero Cup app, and also the organization like the Population Service International, PSI, COCOTAC, and Trust who are the active in the digital health space. The Ministry of Health and Sport has the ultimate responsibility for the health system strengthening, and then also the elected government committed to strengthening the country's health system. Supporting the implementation of the UHC, Universal Health Coverage, also considered as the key policy document of the Ministry of Health, and the most recently Ministry of Transport and Communication provide a free mobile application for the Myanmar National Portal website and aims to access. This is the citizen center approved to access the every citizen to get a real-time information for all the government sectors. So I would like to acknowledge to Dr. John that I learned from today's topic, Digital Health Mission is the best for leveraging information technology and supports the existing health system. Thank you so much.
Thank you so much for your reflection, and it's very valuable. Thank you.
Thank you, Dr. Yadana. Next, we would like to invite Dr. Tepaton to share his experience.
Thank you, Dr. John, for your excellent presentation. I understand that firstly you have the goals, policy, and the strategy of the health sector reform, and also you have the clearly identify the digital health blueprint and good analysis for the building blocks of the UHC in your country. And I understand that you have the good identify the domain of the principle of framework of your work, and to develop the DHL in your country. I think the question privacy and data quality is really important. I would like to say for the Lao situation now, for UHC is the increasing few years ago. Now we achieved the 94%, and we plan to achieve nationwide 2025. For the issue, I think the same with your country for the healthcare access in the remote area, and also the health care quality. So that I particularly note that your lesson is the really useful to Lao context as well. So if you can say your work or your experience, I think will be appreciated. And I have the question to you. How you plan to expand to the nationwide of India, and when you have the step or by step, or you will expand to the nationwide and.
So thank you for those comments. If I may respond. So see, first of all, I am not representing the government, so I am not in a position to answer some of these questions, but you make very valuable points with regard to the framework that is, or digital health public goods that are developed in our regional countries ideally should be made available to others. I'm sure development organizations as well as multilaterals and WHO and Asian Development Bank and others would be more than happy to facilitate some of these things. So, but then, like I mentioned to you, I am restrained that I am not a representative of the government to make such commitments. Nevertheless, I'm sure that would be something the government would certainly consider once we are established and running well. So on the second question which you asked, is there a plan to expand to other states? Yes, like I mentioned to you, they tried the health ID and these frameworks in the union territories, and they evaluated that, and based on the evaluation and feedback mechanisms, they have refined some of the processes, and like I mentioned to you, in a phase-wise manner, they are going to be launching in a couple of states starting January, and then again, it would be an iterative process because as you know, India is a very large country. It is wide, and like also I mentioned earlier, it has a federated there is a federal government and a state government, so there are nuances in implementation because some of the um, on the ground implementation and decisions around that are by the states. So it would be a really engaging, participatory, and iterative process. And right from the beginning, the Secretariat of the National Digital Health Mission, which is the National Health Authority, has been in a consultative process, engaging with every state in the country and keeping them appraised of what is happening, the progress so far on various components of this, and almost on a monthly basis they have regular exchanges where the concerns that are raised are addressed. And so yes, there is a plan to expand, but if you ask me which states are going to be launched in January and which in March and April, I wouldn't know that. Again, like I mentioned earlier, it is a phased manner. They are planning to roll it out in a phased manner and learning from each of the implementation and iterating along the way.
Okay, thank you.
Thank you, Dr. Tat. Next, we would like to invite Dr. Tandat to share his experience.
Hello, I'm here. Thank you for sharing the presentation of India. Yeah, I'm very impressed on the easy is the sandbox environment, because in Vietnam now we also have a kind of this environment for development of the new technology software. And I'm very glad if the AHIN and India can sharing and guideline the model of the sandbox for the ASEAN country, related to the health, the digital health in Vietnam. We identify three main pillars for the health digital. The first pillar is the digital transformation for the preventive healthcare, and the next pillar is the digital transformation for the treatment for the hospitals, and the third pillar, we identify the digital transform for the health management. And in several years, Vietnam developed the digital health is strongly in for example, in the 100% hospital in Vietnam, we have a hospital information software, and we have 10 hospitals have a full electronic medical records, and we have more than 20 hospitals implement picture archiving system. In the preventive in healthcare in Vietnam, we have implemented immunization information system from the 2018, and we can manage all the children, all the immunization for children in Vietnam. We have yeah, and we have communicable disease and so on. And in the management, in the health management system, we have a health online public service system, and connect to the national health health portal, national portal, and the ASEAN portal, and the Ministry Health. We have also have architecture version 1 from the 2015, and we have the in enterprise architecture for healthcare for health sector in the in the 2015, and we also have a circular required on the electronic medical record implemented following the Fire version 4 or higher, and we also implement an electronic health records with the target that in the 2025 each people in Vietnam have electronic profile online, and now almost province in Vietnam implemented the electronic health record, and the objective of us is to push on the hospital, at least which hospital in the province and in the national level implement full electronic medical records, and lead to paperless hospitals. Yeah, in the AI, in the artificial intelligence, we also have some advantages. The first, we also implement the machine learning system for the cancer, for cancer in some hospitals, and we have a chatbot for automatically answers the people about the COVID and about the another disease, and in the end of this year, in the end of 2020, we will have healthcare social networks. We connect all the health workers in Vietnam together, and we can sharing electronic medical records in the health social networks. And by the way, I will inform that in this month we will have a national health digital health conference with the joint of the minister and prime minister of the Vietnam, and we also invite him to have a presentation on this conference. Yeah, and as in conclusion, in fact, we want in the presentation, I really want you can share the experience to develop the sandbox environment, because it's the one of the target of us in next year. Thank you.
Thank you so much for those nice comments, and really impressed with what all you are doing in Vietnam. And we've been reading in the news also how you, the country has been managing to keep COVID under control, and it's really heartwarming to know that a chatbot-based approach also has been used to do that. And on your request about somebody speaking about the sandbox environment, I will be in touch with Jay Ganesh, who is on the AHIN council, and we will arrange somebody to share about that. Thank you so much for the opportunity.
Mr. Laura, the floor is yours.
Hi, good morning from Canada. First and foremost, I'd like to congratulate India for making some great progress with the development of the nation's architecture. If there's a couple of things I'd just like to add, since my fellow reactors have covered most of it. I guess I'd like to just make a comment that we can all learn from this. Clearly, the National Health Policy of 2017 is that point in the spear that essentially, creates the environment and the commitment, basically, to use digital health tools to be able to drive that health reform for access to affordable healthcare. And because of the National Health Policy of 2017, it was very clear that India was very deliberate in its intentions to use technology. Fairly ambitious, but certainly if the will is there, I mean, this can definitely be all achieved. If I can maybe give you some lessons from the Pacific region, where I spend a lot of my time on, we need to really focus on the foundational pieces to make sure that we get it right, because everything else will be inconsequential. One of these foundational pieces is, the notion of a unique health identifier, which Dr. John has mentioned. That needs to be legislated. It has to be universal. It needs to exist from birth to death with some unique authentication. This will only, if you do that, you would be able to meet your design principles of inclusiveness, accessibility to healthcare, and so forth. So that's pretty much about it from my end. So thank you very much for the opportunity to participate in this.
Thank you so much. Yeah, you make a very, very valid recommendation on the legislative part of the health ID, and it's a little of a sensitive topic in every large democracy as it is, and I'm sure it will get done. But on the uniqueness of the ID, I think there are several health informatics approaches to achieve this, such as the master patient index and things like that. For a large country, it's a big challenge. Nevertheless, it needs to be done. If you get the building blocks right up front, then it can be achievable. Thank you so much for those valuable inputs, and I will convey it back to the ministry. Thank you.
Thank you to all our reactors for sharing the country experience. We now open for Q&A. Mic already enabled. Please feel free to ask your question. Dr. Jong, do you have any question?
Yes, I do. Thank you very much. Good evening from the Philippines. I'm Jong De Castro from the Center for Informatics at the University of San Agustin. We are an academic center and we focus on health data. My question is this, Dr. John. Have you encountered any tensions with private health corporations, for example, with regard to the rollout of your plans, or do you anticipate any tension? Because usually, there is some pushback from private entities, particularly if a lot of the recommendations affect their bottom line, and also with regard to regulation. My other question is, what are the provisions you have made in your digital health plan, National Digital Health Plan, for emerging technologies such as genomics, emerging technologies for health, such as genomics, AI, ML, as well as blockchain technology?
Thank you. You are bang on target on the controversies and challenges. But that being said, I did allude to it in my presentation, saying that the government is only envisaging to build core components, and it envisages every stakeholder, be it a public enterprise, or be it a developmental agency, or be it a private for-profit large corporate entity, to plug and play. So when you have the basic infrastructure or the backbone, as it were, and if someone wants to create let's say an analytics based offering that is offering frontier technology based insights to healthcare providers, provided the privacy and security and confidentiality and all of those boxes are ticked off, it is really a huge playing field. And I think the private sector has been extremely enthusiastic about engaging on the sandbox. And this has been one of the biggest highlights of the program, because the core infrastructure is being built by the government, and it is saying that here is an opportunity. Everybody who's interested in developing a patient-facing app, or if you want to provide a personal health record, as long as you are complying to the standards, you can offer one in the market. And all you need to do is that you have to get certified that you are complying to the standards and that you are sticking to the norms. So I think it is quite disruptive in the approach that has been thought through. Yes, but we will have to wait and watch, because you never know how some of these things turned out. But at the moment, everyone is very, very enthusiastic about the whole concept. And I do see a lot of comments around the sandbox. I'm sure there might be an opportunity at a later date to perhaps even demo an example of how the sandbox environment works. And I will work with Jay and Alvin and others and come back to you all perhaps to showcase some of that. Thank you for your valuable reactions and questions.
Yes, thank you, Dr. Oommen. I think we have another question from Engineer Derek Ritz.
Thank you. This first, to just compliment the excellent presentation. I enjoyed it very much. I want to ask particularly about consent management. And this, of course, privacy is crucial for any working system in healthcare. But I noted that you have the ability for people to withdraw their consent to collect. It's very common for people to withdraw their consent to disclose, but if you can withdraw also your consent to collect, it can undermine important public health reporting workflows and insurance transaction processing workflows. And so I'm curious about the ability for somebody to withdraw their consent to collect. And also I noted that it seems to be an opt-in versus an opt-out consent management posture. And I have to say, in my experience, it's very challenging to operationalize an opt-in consent management solution. So please, can I ask particularly about consent management as part of the overall architectural design? Thank you.
So I'm afraid I do not have too much of insights on this, but what I understand I can share with you. Otherwise, I will let Jay speak on this. But what I understand is that there is a consent management layer that is general. It's not only for health, but right across the board, which is being put out by the Ministry of Electronics and IT. So that consent management mechanism is the one that is being also used here. I think it's slightly different from opt-in versus opt-out, because here what is specifically saying is that let's say I have a certain set of health related data in my personal health records, which would be under a health locker. And if I were to seek care from somebody other than my primary healthcare provider, I could offer consent for him to access that particular episode related thing. Or let's say I have a lab investigation that I've taken from a private provider, and I want to preferentially give access to different healthcare provider to see or view that report, and it is for that specific instant that that consent is available. And the moment that instance is over, that third provider who had access to look at my laboratory report is no longer able to do that. So it is instance based and episode based, and not essentially an opt-in versus an opt-out, as I understand. But I would welcome Jay's comments on this, because he might be more familiar with this.
Just to be clear, you're talking about the PHR, not about the EHR. Do I understand that correctly?
So this is the consent bit is at the level of the citizen of the data they hold.
Right. And the system information that is held about them in their longitudinal electronic record, is that?
So the longitudinal electronic record is still being envisaged in terms of the clearly articulated aspects of that have not yet been put out. So it is yet to evolve. So at the moment, it is on the health ID, the registries have been launched, and a PHR concept has been launched. And we will need to wait and see what is the specific aspects of the EHR that is going to be put out. But I would see I definitely see a point in what you are saying. So specific public health related data such as immunization data, or access to antenatal services. If somebody opts out, then your indicators will suddenly change, and that might not be in the best interest of both the individual concerned as well as the health delivery system.
Thank you very much. And again, a wonderful presentation.
John, I have a question. Can you hear me?
Yes, Fazila, thank you.
Yes, Fazila here.
Yes.
In your technology principles, you had one called leverage legacy. That's very interesting. Could you just elaborate on that? And also one more is, I did not see anywhere about your connectivity plan as a nation. Is it part of this national digital health plan, or there is someone else who's doing it? Thank you.
Yeah, thank you, Dr. Fazila. That's an important question. So, as you would be aware, we do have systems that are currently in place, such as our TB program has a very robust digital architecture and framework with notification to the patient, the provider, and it is highly engaging. So that is one of the systems that is already there. We have a huge program around non-communicable diseases, which again is on a digital platform. It's called the NCD application, and a whole infrastructure around that. Most of the maternal and child health, RMNSH, right through is on a digital platform. The frontline healthcare workers use an ASHA platform or an animal platform. Almost every state has its own frontline healthcare platform. Now, a lot of the digital health infrastructure is already existing. So you cannot get rid of it one day and say that we are all moving to a new system now. Let's forget about all that has happened in the past. So that is where the legacy bit comes, and it's not going to be very easy. Nevertheless, it is being thought through, and because of the fact that National Digital Health Mission was in the pipeline, many of these applications have been working towards interoperability in a broader sense. And so, for example, the TB system now is interoperable with the non-communicable disease system and with the infectious disease notification system, or the IHIP, the health information portal. Which all the notifiable diseases come through a notification system, which is laboratory linked. So some work in the background has happened around interoperability on that front, and somewhere all of that will get plugged into the larger thing. So that is on the legacy thing. In terms of the connectivity, Dr. Fazila, there is a broader digital India mission, which is much more broader cross ministry initiative, largely led by the Ministry of Telecom and IT. And that is where the infrastructural capability on the telecom network, as well as the broadband and rural connectivity, is being expanded. And as of last week, our parliament just approved a digital, although it's called digital or data centers, these primarily making sure that low highly affordable, low cost data services, or almost free data services, are going to be available in rural and remote India. And this is seen as a means to actually leverage on the broader Digital India mission. So I can share some specific white papers around that framework. And then there are white papers and policy documents on how frontier technologies are going to be used in health and broadly across other segments as well. There is one very strong one for education, agriculture, manufacturing, and health from our planning commission or Niti Aayog. So these documents are available, and happy to share them with you.
Oh,
Thank you.
Thank you, John.
Hello, Dr. Fazila. I think Dr. Alvin has a question for you on who is authorized to set sandboxes in your country.
Oh, sorry. Okay, the sandboxes is done by the, there's two sandbox. The regulatory sandbox is done under another agency. We actually started that because of the autonomous vehicle. And the National Technology Sandbox is done by the agency that looks into innovation. So all the other ministries can participate, stakeholders of this sandbox. So it's done at the national level. So many ministries can make use of it and collaborate that. So ministries don't have to do it individually. Yeah, maybe one of these days I can share on that.
Thank you, Dr. Fazila. Thank you for sharing your work with us, Dr. John, and thank you also to our actors from Cambodia, Laos, Myanmar, Vietnam, and Finn, and of course to all our participants who joined us today. We also hope to see you tomorrow at 8 p.m. with Professor Philip Zuniga, who will be talking about the role of standards and interoperability in the Philippine COVID-19 response. And please also join us in the upcoming AHIN General Meeting on all Thursdays of January. So to register, please visit ahin.org/7gm. All right. Thank you, everyone, and have a good night.
Thank you. Thank you, John. Thank you, man.
Bye.
Bye.
Thank you so much. Thank you for having me. Pleasure.